So once again, thank you to the organizers, particularly Jens and Rick, for having me out. Andrew charged me with giving an update on trauma to the spinal cord to lead off his session, and I'm going to try and do that, but it's an interesting story, and the message that I hope to leave you with today is that it's still very much in evolution. So I don't have anything to disclose, and as we transition into this talk, of course, the injury that occurs at the scene is the primary injury, and it's described in terms of really mechanical forces to the spinal cord: contusion, compression, deceleration, shear, distraction, and et cetera. And really, that's fait accompli. It's not really something that we're able to treat at this time unless we try and use a regenerative strategy. We're really talking about trying to prevent secondary injury. And there's certainly been a lot of laboratory work for that. It's really distilled down into three main pillars, but the number of pathways involved in these is huge, and work continues. It's probably a multitude of pathways, not just a single magical pathway to help get us to reduce the injury in the secondary survey. But there has been animal studies, and I want to plant this seed because we're going to come back to it, to suggest that if you look at the amount of primary injury versus the amount of secondary injury may actually represent about 10% of the total neurologic deficit. So bear that in mind. It's an uphill battle all the way. We're not at this point able to recover 50% of the spinal cord. About 10 years ago, there were a group of 9 of us charged with looking at the guidelines for the acute care of spinal cord injury. And I want to acknowledge that Bijan Arabi is here in the audience, and he was part of that group. I was lucky enough to be part of the group. We've heard from Hopkins today, and Nick Theodore is with us in spirit, although he's not with us today. But rather than just really go through the guidelines, which were published in 2003 in the journal Neurosurgery, what I really want to do is put this in a clinical context. And so I want to combine the guidelines information with more physiologic principles, which we understand already to be true. We don't need randomized controlled trials to tell us about normal physiology, and hopefully give you something to take home that helps you understand why we do what we're doing today, not just because of clinical evidence. So it's easy to think of this in an ABC kind of environment, and I want you to remember that A stands for arterial oxygenation. And so it's close to the ATLS protocol, but not really. A is arterial oxygenation. And important in that is if you're thinking about, now if I use the pointer, the community can't see it. You have to use the cursor. Right?
Yeah, you have to use the cursor.
Yeah. If we think about spinal cord injuries, what we need to remember is anything above T6 is going to start to interfere with the majority of your intercostals. Below T6 doesn't seem to matter. Above T6, you're shutting down more than half your intercostals. And in addition to the intercostals, of course, above C5, we're into the phrenic nerve territory. So when you get an injury up in the high cervical spine area, you already should start think about loss of complete respiratory function. Knocking out anything above C7 is going to lose the cardiac sympathetics, and it's also going to lose the peripheral sympathetics. Now that's important, the peripheral sympathetics, not only for vascular tone, but bronchial tone. And I'm going to come back to that. We're talking about arterial oxygenation here. The combination of bronchial tone and vascular tone provides ventilation perfusion matching. And when you knock out both of those, you can imagine what's going to happen to your ventilation perfusion parameters. All right, so as we're sitting here, your lungs are oxygenating your blood through the heart, taking it to the most important organ in the body, the spinal cord. And hopefully you've got a capacity of 100% of a forced vital capacity and a negative inspiratory pressure. And your O2 sat, I hope, is running around 93% to 98%. Depending on whether you're a smoker or not. Who does that anymore? But within seconds of an acute cervical spinal cord injury, the FVC and negative inspiratory pressure drop to less than a third. So imagine you trying to sit here now and ventilate on less than a third of what your pulmonary capacity normally is. And when you're ventilating on less than a third, guess what happens? your dead space increases threefold as well. So now you've also not only ventilating less than a third of your normal capacity, but a third of that is now dead space, whereas less than 10% of our normal breathing is dead space. Combine into that another phenomenon, these arrows. Now, because your chest wall has no tone at all, it's flaccid, there's this syndrome called paradoxical breathing, which conspires even further to reduce your ventilatory capacity. So with a combination of paradoxical chest wall movement, accessory muscles of inspiration, relative increase in dead space, and this ventilation perfusion mismatch that I mentioned, over on this side, what the heart sees, as you can imagine, is a decreased amount of oxygen that it's going to be able to pump towards that injured spinal cord. Look back up here on our graph of forced vital capacity. Within hours of a cervical spinal cord injury, this happens. Maurizio, do you know what that is? Why would FVC and negative inspiratory pressure drop even more in hours?
Do you want to bring a microphone? Or you have to say
No, it's okay.
microphone?
I'm just making them wake up. But I know he knows the answer. It's because your accessory muscles, which you don't normally use to breathe, start to fatigue. If you pump a biceps on 40 pounds, try doing that for 8 hours, right? How far do you think you're going to get? So your sternocleidomastoid fatigues, and all of a sudden now, within hours, usually in the intensive care unit, this slips down into anaerobic, and you're now sending low oxygen blood, hypoxic blood, to an injured spinal cord, which is a bad idea, right? Now, this isn't permanent. What I did want to point out, though, right up to this point, O2 sats are normal. It's not until you start sending off hypoxic blood that the O2 sats are going to fall. And so if you're only monitoring O2 saturation in the intensive care unit, you've got a problem because the horse is already out of the barn. Eventually, this gets better and goes away. Patients are able to breathe on their own, even quadriplegics. And again, Maurizio, you know the answer why, right? I keep... And one other thing so Maurizio said the scalenes come back, they get stronger, and also the other thing is they get spastic. The chest wall now becomes spastic like their legs do, and so the paradoxical movements go away. And now they've got some stiffness to the chest wall. But this should hopefully not be too unfamiliar to you. This is the hemoglobin oxygen dissociation curve. And on the y-axis, you can see oxygen saturation of your hemoglobin molecule. And on the x-axis, you've got the partial pressure of oxygen dissolved in the arteries. And what I really want to show you here is up at the top of the curve where we are right now. This is where we are right now. There's this magic number of 80 millimeters of mercury, below which we know from mammalian systems, every mammalian system below 80 millimeters of mercury, you start to go into anaerobic glycolysis and hypoxemia, right? So the other thing to point out here, again, one of my pet peeves is if you're monitoring oxygen saturation, look at how far you're going to drop. I keep losing my mouse, sorry. Look at how far you're going to drop down this curve before your O2 sats actually get down to 90. You're going to be way into anaerobic metabolism. So O2 saturation is not the thing to monitor. Intubation occurs in 1/3 of cervical spinal cord injuries, most within the first 24 hours. And these are the things we see and we can put a feeling on, but they're very hard to really tell you when to intubate a patient. You have to do it proactively. If you ask yourself, what are the two most important predictors of which spinal cord injury will need to be intubated? It's actually kind of a no-brainer. Think about it. Think about it. Level of injury, the higher the injury, and the severity of the injury. But again, as we start to talk about the changing morphology of spinal cord injury, these injuries with this kind of signal change in the cord, sorry, let me try and back that up. This kind of injury with this kind of signal change in the cord should all of a sudden make you think C5 keeps that patient alive, and I'm going to have to be really aggressive about that. And so you already saw the answer. What percentage of patients with C5 Asia A, that's high and that's complete, eventually require intubation, greater than 90%. Do it early. Don't do it late, right? So as far as the guidelines go, it's level 3 evidence, which is retrospective evidence, but cardiac hemodynamic and respiratory monitoring are recommended in an ICU with acute SCI. Always put them on supplemental oxygen, even if they're not intubated. Watch their negative inspiratory pressure and forced vital capacity. Use those to monitor and intubate. Do not rely on O2 saturation or PCO2 because of that ventilator perfusion mismatch. B is for blood flow, and this again is, I think, an important concept to wrap your head around. This was work done from Martin and Doberstein in 1994 on monkeys, but it actually has to deal with cerebral blood flow, and the normal cerebral blood flow in the gray matter is 50 to 55 milliliters. I'm sorry, the mouse keeps advancing. Let me back it. 50 to 55 milliliters per 100 grams per minute. But what's interesting is if you fall off that curve, if you turn down the blood flow to the brain to half, now you start to get altered EEG and impaired consciousness. If you just drop another couple of points, you start to develop neurologic deficits or coma. Slide down a little bit farther, loss of evoked potentials in the sodium-potassium pump, and then by the time you hit 10, complete ion pump failure, cytotoxic edema, the ion channels open, and you get cytotoxic death within minutes. The thing is, this has been proven true for the spinal cord as well. It is central nervous system tissue. And why is that important? Well, when Dr. Chapman gets up to ask questions, why doesn't his blood pressure fall into his boots and he gets cerebral hypoxemia just from standing up? Or when you're hungover the next day and you're dehydrated, what prevents you from having a stroke and losing your vision from your posterior cerebral artery territory circulation? Well, it has to do with this. And this is the second component besides cerebral blood flow or blood flow itself. This phenomenon is something where over a range of normal systolic blood pressure on this axis, your blood flow, spinal cord blood flow, cerebral blood flow actually stays constant. So when you get out of bed, when you're dehydrated, even in some trauma situations within a certain limit, you maintain your blood flow even though your blood pressure drops. What's it called? Autoregulation, right? So we're going to combine autoregulation and we're going to combine it with blood flow, and I'm going to show you why that's important. You've all heard of maintaining MAPS in the spinal in the ICU. This is why, all right? This is another way to measure autoregulation. If you increase PaCO2, your arteries dilate and your blood flow goes up. That's autoregulation. If you hyperventilate, your arteries close down and you vasoconstrict and your blood flow goes down. But in a setting of trauma, that flatlines. So autoregulation is lost in the setting of trauma. Why is that important? This is a longitudinal section of an injured spinal cord. There's the epicenter of the injury. Here's the blood flow diagram we looked at. Remember, normal is up in the 50 to 54 range. This is the slippery slope where you start to get neurologic deficits. At the epicenter of the injury, blood flow is 0. As you work out into the penumbra of the injury, your blood flow starts to go up, and this is the at-risk area of secondary injury if you're delivering hypoxemic blood and low blood flow. We also said that normal autoregulation in spinal cord injury is lost, so instead of a nice normal homeostatic blood flow in spinal cord injury, it's lost. So if you drop your blood pressure, your blood flow is going to go down. The good news is, well, here's the bad news first. Cardiac sympathetics and peripheral sympathetics, once you cut those off from a cervical spinal cord injury, that means bradycardia and hypotension. So you're already battling this in the ICU. And guess what? That's going to drop you down this curve right here, and it's going to cause your secondary injury to increase. The good news, and this is where it comes from, is that if you pump that back up by increasing your mean arterial pressure, you do, because autoregulation is lost, you can push this back up into a more safe area. So that's the whole physiologic reason behind pushing MAPS. Is there any clinical evidence to it? Yeah, the big paper came out of Alabama, Mark Hadley's group, and they compared their ICU experience to historical controls. But this is a graph showing the percent of their patients that were ambulatory on discharge that were ASIA A's. And I think that says 3 out of 10 of their ASIA A's walked away from the rehab institute, 5 out of 6 of their ASIA B's when they maintained MAPS above 85. So that's the kind of retrospective data that we have clinically. Similar findings in the thoracic spinal cord for their group. And there's been some other literature as well, all class 3, but all of it shows a benefit to maintaining MAPS. So that pretty much, for the guidelines, is a recommended treatment management for spinal cord injury: correct hypotension and maintain MAPS 85 to 90 for 70 days, based on level 3 evidence, but also based on good physiology. C is for complications, and I don't want to spend too long on this, but there's something really interesting here. Pneumonia is the leading cause of death, and we all see pneumonia in our spinal cord injury patients in the ICU. Loss of abdominal muscle control, strep, Pseudomonas, and staph. But here's the real kicker. The American College of Chest Physicians, these are pulmonologists, say to have pneumonia, you need to meet at least 2 criteria: temp greater than 38 or less than 36, leukocytosis or leukopenia, purulent secretions, or hypoxemia. Does anybody see a chest x-ray on there? No. Chest x-ray is not part of the diagnostic criteria for diagnosing pneumonia in the acute stage. The chest x-ray lags by 2 days. So if you're waiting in the ICU to treat your spinal cord injury patient for pneumonia based on an x-ray, you're going to be behind the ball already. Thromboembolism, this is not rocket science and won't be new to anybody. It's very common. Prophylaxis is based on level 1 evidence, prospective randomized level 1 randomized clinical trial, and I think we all know the options for that. So the level 1 guideline, which implies standard of care and possible negligence if you're not following this guideline, the use of low molecular weight heparin, rotating bed, or combination is recommended. If you're going to use low-dose heparin, not low molecular weight heparin, you should use the low-dose heparin in combination with pneumatic stockings or electrical stimulation. D is for decompression, and this is probably the most famous study. It really is interesting data, and a lot of effort went into this. Bijan is an author on this, as well as several other, which you'll recognize. It came out of the AO group. Retrospective study, and it was multi-center observational from 2002 to 2009. Comparing early, less than 24 hours, and late surgery. And the change in ASIA grade was picked as the primary outcome. So they wanted to see a minimum change of 1 grade at 6 months as a beneficial result. There were 222 patients over 6 centers, and it was retrospective, so obviously there was some biases built in. This is the results, and this is where we all fall into that early surgery recommendation is based on the people that changed 2 ASIA grades or 3 ASIA grades. But the issue I have with the study, the thing that just doesn't seem right to me, is that the majority of the patients in both groups only changed 1 grade. And if we really did have a robust, non-biased, if we had a robust biological effect here, honestly, we should see the same trend in the ones changing 1 grade. It doesn't make sense that they'd change 2 grades, but some of them wouldn't change 1 grade. So again, that's a problem with the retrospective study. But if a picture paints 1,000 words, I want you to look at this study. This is a classic paper from the lab of Chris Shields in Kentucky, and as it turns out, Steve Glassman was the second author on this paper. But they looked at a number of rats with the impact model for the spinal cord. What they did after the spinal cord injury is they took a spacer and they put the spacer inside the canal after the injury, and then they left the spacer in the canal for various periods of time. And here's what they found. Now, I want to ask you this. You look at these cross-sections of the spinal cord. You tell me, if you have a spinal cord injury, do you want your decompression at 0 hours, 2 hours, 6 hours, 1 day, or would you rather have your spacer taken out of your spinal cord at 3 days, right? Mm-hmm. You don't need a prospective randomized trial to tell you what's going to be better. And as it turns out, the functional data, the ability of the rats to ambulate, it mirrors what you just saw on the pictures. This is a BBB scale, which is the ability to ambulate in an open field. And this is the post-op time in days. Those that were decompressed early were able to come closer to normal ambulation. Those that were decompressed late didn't get that far. What I do want to point out in this study, though, is that all of these groups are incomplete spinal cord injuries. You're not seeing any animals here that were treated with complete spinal cord injuries. So to put that in perspective, I want you to think about this graph. On the lower axis, let's think about the number of intact axons, 0 up to 100. 100 is 100% of normal axons. On the y-axis, let's think about neurologic function. Motor and sensory, complete loss of function, normal. So it makes sense. The more axons you have, the more normal your function, but it's not a linear relationship, of course. It's a sigmoid relationship. And what that also implies is that below a critical mass, no matter how many axons you have below that critical mass, you'll have no function. And it also implies that above a critical mass, you're going to have redundancy and very little change if you're recruiting additional axons. That's why myelopathic patients can go for so long before they actually fall off the slope. Remember I said animal models suggest 10% salvage of secondary injury, right? So if we consider an injury that happens at this part of the slope, and then you recover this much by preventing or ameliorating secondary injury, that's going to be a huge improvement in functional outcome. So that's why incomplete patients, it's so important to get them treated and treated well, not just decompression, but all of the other things we've been talking about. However, if you move this down the slope, this is why your complete patients don't do very well, because we're only recovering a certain percentage of those axons. And if you start down here, it's not going to help. Even if you start here, moving them up the slope this far is probably not going to be a great thing for them. So that's where the don't operate on completes. It's not that you don't operate, it's just that it's not going to have the same effect as operating on an incomplete. E is for extras, and I'm not going to talk about steroids, Jens, despite the bait you threw to me. So there are no extras. There are no drugs that have been shown to help in the treatment of spinal cord injury. Instead of worrying about whether or not you're going to give steroids, please concentrate on these 4 at the top. It's so much more important. Now, in the last 5 minutes, just when you think you have everything figured out, guess what? Something else happens. Yep. And thanks to Dr. Arabi and his group, we have the efficacy of ultra early, and late surgery in a group of patients from Baltimore shock trauma. They looked at a retrospective series over 12 years, 72 patients, kept the maps at 85 to 90 for 7 days, and then they looked at the ability of these patients to change at least 1 ASIA grade. So this is the percent patients that were converting by at least 1 ASIA grade. And here's the ultra early surgery, and late surgery group. And guess what? No difference. Doesn't that just violate everything that we talked about, right? In fact, if you look at it, there seem to be more late surgery patients doing better, changing grades, than early surgeries. And what Bijan was able to conclude with this data is that the timing of surgery does not influence outcome, and the intramedullary lesion length seen on the MRI does correlate with ASIA conversion. How are we going to put this in perspective, though? Well, I think it's got to do more with this. The mechanism, 50% falls, 30% motor vehicle accidents, and 20% other. What do I mean by that? Well, we looked at our own data at the University of Arizona. We did a retrospective review of January, December, just in 1 year, this last year. We looked at all neuro and ortho patients undergoing surgery for cervical spinal cord injury. And what we found were 54 patients treated in that 12-month period. And here's what we had. 11 of them, or 20%, had fracture dislocations, or 80%, 43 of them, had no fracture dislocations. That's a complete flip. When I was training, it was the other way around. 80% of patients had fracture dislocations. We boiled this down a little further. Look at the ASIA grade. Here in red is the fracture dislocations. The majority, ASIA A's, that fits with the usual spinal cord injury, ASIA B's, and then the minority were ASIA D's. Look at the no fracture dislocations, which make up 80% of our patient population now. The majority are ASIA C's and D's. So we've seen a complete reversal in the demographics of this kind of injury. Motor deficits, not surprisingly, in the red, fracture dislocations. Legs are affected just as equally as arms and hands, but in the non-fracture dislocations, hands are affected more frequently than arms and more frequently than legs. So we also In fairness to Bijan, his group identified this very elegantly over 20 years of data and 1,400 patients in Baltimore Shock, and showed that this is a trending thing that's happened gradually over the last 20 years. Well, let's step back then. The mechanism of spinal cord injury is high velocity, high impact, acute canal compromise, indiscriminate axonal injury, and sagittal translation causing long tract shear. That's why you lose your legs. That's why you lose your hands, right? As we're looking now at the no fracture dislocation group, somebody like this with signal change, what we're seeing is low velocity, low impact, pre-existing canal compromise, hyperextension injuries, and generally selective injury that affects the hands and in numbness and weakness and tends to spare the legs. What are we talking about? Well, most people here know that we're talking about central cord syndrome, right? That's really what we're talking about. And so now, Sir William Thorburn described it first way back in, I want to get this right, 1887. He described one case out of the University of Manchester, but it really was Richard Snyder from University of Michigan who put together 8 cases of central cord syndrome. And he prescribed conservative treatment, non-surgical disease, because many patients spontaneously improve. Fragile cervical cord could be injured during decompression, and often the neurologic findings are mild. What's happening? What's happening to the mechanism? Why is this different than spinal cord injury? I want to show you that. Think of a bunch of spaghetti, right? And those are the long tracts that go from your head down to your feet. Those are the long tracts, the spaghetti. And then think about when you get pre-existing cervical spondylosis, you're going to have compression of that spaghetti from front and back. So you're going to spread it out. You're going to fold it out. It's going to disperse the axons, and they're going to tend to migrate laterally, because this happens slowly over time, right? But then you get a bump, and you get a spinal cord injury from it, and you get this horizontal shear that temporarily is increased. So what is it that takes out the hands, which has to be somewhere in the middle of your long tracts, not down here where the legs are? What is it in there that's being injured selectively with this injury that gets dispersed axially and then causes the injury? Well, the answer comes pretty easily, I think. If you look at the microvasculature, you've got very, very small arterioles, and if you start to stretch them laterally, they're going to be one of the first things, especially in the gray matter, which is where the central cord is, by the way, when it's dispersed laterally. And in addition, the other thing that most people don't think about are the second-order crossing sensory axons, which, by the way, in the level of the cervical spine, supply what? Sensation of light touch to your fingers and to your hands, right? So it's those second-order axons that are coming in from C8 up around C5 that are crossing over and trying to get up on the contralateral side. So those are the two things that are probably injured in central cord syndrome. If you think of corticospinal tract, which is hand function, and gray matter, which is also sensory function to the hands, then you have your disc osteophyte and your ligamentum flavum dispersing axial contents laterally. And then as you get laterally, they try and expand again outside of the zone of compression. So the forces really are transmitted in this direction. And a mild injury is going to affect the epicenter of where the compression is, hand numbness. A more moderate injury is going to start to affect corticospinal tracts, which is hand dexterity. And as you can imagine, a severe injury, a severe central cord injury, can result as an ASIA A patient. That's new. Nobody has said that central cord could be a ASIA A, but in this new paradigm of thinking about it, it certainly can be. We looked at central cord syndrome in the guidelines. We came up with some retrospective conclusions, but there is nothing written about the timing of surgery. So when we come back to Bijan's paper about timing of surgery affecting central cord syndrome, we know nothing. We don't have the data. So here's Hurlbert's guideline, and only because I say so. If you have a central cord syndrome, no fracture dislocation, and the patient is deteriorating, that probably warrants emergent decompression. If the patient is neurologically stable or improving, urgent or elective, I think, is an option. What about non-operative treatment? Possibly as well. The key points here I want to leave you with before I move on to my last slide. Central cord syndrome is post-traumatic neurologic deficit localizing to the cervical spine, pre-existing spondylosis. There's no fracture dislocation. It can be Asia A to D. It's the most common type of cervical spinal cord injury we are seeing now, probably across the nation. We just don't have the right data to show us. The mechanism is not equal to spinal cord injury with fracture dislocation. The clinical presentation is different than typical spinal cord injury. The pathology is different. Decompression and stabilization can be done emergently, urgently, or possibly even electively, as long as the patient's neurologically stable or improving. Now you're going to hear, and I'm holding my breath to hear about this because Bijan again is on the cutting edge. He's going to talk about duroplasty and compartment syndrome in this setting. But as we go there, I want you to think about my patient, Mr. CI. He was a 37-year-old big African-American guy, looked like he could have been a football player, healthy. But he came in changing flights from Las Vegas, trying to get to Houston, and he tripped on the ramp between the airplanes coming into the airport. And he fell, and he experienced bilateral hand and forearm burning dysesthesias and allodynia. His strength when we saw him in the ER was 4 to 5 out of 5 in all groups in his upper extremities, a little bit of weakness in his hands, normal in his lowers, and here's his MRI. And I think you can appreciate that there's some signal change in the setting of pre-existing spondylosis in a otherwise 37-year-old healthy guy. We took him to the OR within 18 hours of his injury, and we used the Stryker bone scalpel to gently lift that lamina off. Multiple segments we wanted to decompress widely. And he ended up waking up with 0 out of 5 strength in his hands, 0 out of 5 in his wrists, 2 to 3 out of 5 in his elbows and shoulders, and 4+ in his lowers. And we were careful. And we repeated his MRI, and you won't be surprised to see a whole bunch of new signal change, right? So as we go forward and we try and define how to treat this new evolving common picture of spinal cord injury, early surgery may not be the answer. It may be better. Schneider may have the answer in saying that this should be left alone for a while and let it to cool down. And that's where I'll leave you. More questions than answers. So thank you.
Great, John. Thanks so much for that. Just a quick question. You know, do you push the mean arterial pressure for 7 days in all spinal cord injuries? And if so, is there anything to identify the risk profile of that? Because I've had some patients who've developed ileus, you know, at 5, 6, 7 days, and you're wondering, what am I doing? Am I just killing them? Yeah. And it's really problematic for me. And I just worry we're causing complications with that too.
I agree. It's a balancing act, and not everybody can tolerate it. You have to try and figure out when it's best to back off. But does it make a huge difference? I honestly, pushing the maps, I'm not sure it's going to make a huge difference, particularly in this group. But what I do think will make a big difference is letting the blood pressure drop, right? Hypotension is bad. Do you have to push it up as high as 85? Probably not. The other thing in the central cord group, a lot of them have normal maps to begin with. A lot of them are incompletes, and you'll check their map, and it doesn't really need to be pushed. But good point, Andrew.
Other questions for John? Yeah.
John, do you think that the blood pressure locally, the blood flow is changing during your decompression, and that makes the difference?
Yes, I think what we're seeing here is a reperfusion injury.
So is there a way to control that intraoperatively?
Right. I think if you're going to do a decompression acutely, my suspicion would be no. The only way to control that is to let it settle down, give it a couple of days as long as they're not deteriorating, and try and do it in a less emergent situation. But I'll be interested what Dr. Arabi has to say about that.
Okay. Well, in the interest of time, thanks so much. I mean, there's